Hey, it's Justin Harvey. Thanks for tuning in to the Anesthesia and Pain Management Success podcast. With APM Success, we take a close look at important topics pertaining to business, practice management, personal finance, and careers for anesthesiologists and pain management physicians. We work hard to take your critical questions straight to the experts. Thanks for listening. This week, I'm joined by my friend, Dr. Aalap Shah. Dr. Shah has functioned as an anesthesiologist in many different practice models, and today we talk about his experience in running an anesthesia company in Southern California. He takes us behind the scenes to examine many of the complexities of operating a practice. We had really interesting discussion about how contracts are negotiated with hospitals and some of the challenging parts of navigating the political landscape with hospital administration. Much of what we discuss today is really embedded in the fabric of anesthesia finances, and these are really important concepts for physicians to understand if they desire to track the flow of dollars related to their specialty through the healthcare system. We covered some really awesome content this week, which we've never broached before, and I'm really excited to share it with you this week. Hope you enjoy. Hello and welcome to episode 70 of the Anesthesia and Pain Management Success podcast. I'm very pleased to have a returning guest, Dr. Aalap Shah. Aalap is an anesthesiologist and a business owner and has taken a really interesting path. I had him on back in the teens to talk about his career as an entrepreneur and anesthesiologist simultaneously. He's continued on that track since we've spoken and has a lot of great experience from which we're going to draw today in talking about some of the challenges faced by business owning, specifically like anesthesia practice business owning physicians. So, Dr. Shah, thank you very much for being here.
Thank you very much, Justin. And again, thank you for having me again on your delightful series. Since we've last talked, I remember the content of what we talked about before, starting off as an independent business owner, as an individual physician anesthesiologist, going and trying to pave a way compared to the confines of a traditional private practice or group practice. Since then, I've expanded on the role, going from simply as an independent practitioner, independent anesthesiologist, to a partnership and running a group with like-minded individuals that are also focused on the same endpoints, giving high-quality care in a cost-effective manner to the areas that need it the most, the medically underserved areas, especially around Los Angeles.
Awesome. And I'm excited to unpack that with you today. One of the things that is a strong personal passion of mine, and the reason this podcast exists, is to equip physicians as much as possible to maintain agency over their own careers and their own decisions around how they practice and around compensation and around the business functions of the practice of medicine. And so connecting with you, early on has been a real fun thing for me. And I'm really hopeful that today's content is going to give our listeners some tools for people who are interested in this, like, running an anesthesia company or even being like a solo anesthesiologist who contracts on their own behalf, to be able to ask some important questions. So tell me a little bit, maybe actually before we dive into what you just described, take a minute and just talk about that first, year or two of attending Hood and what does being an independent anesthesiologist mean in that context?
Absolutely. So a lot of that, I remember touching on that in our previous discussion, but to summarize here, a lot of that requires, first of all, the logistics and the medical legal background. Setting up as an individual corporation, for example, in the state of California as an S corporation. And again, there's a whole separate discussion about W-2, 1099, which always seems to come my way whenever I talk about any practice-related thing. And it's very relevant, but it's important for people to know that W-2, 1099 as a tax setup is very different from that as how you're legally set up to practice in the state of California. So I remember we touched on that briefly last time. After that, a lot of it is similar to that of running any kind of business, especially in the United States. Going out there, marketing yourself, networking, having good quality people skills, being able to work and have the cojones, lack of a better word, to approach administration with ideas, your group leaderships with ideas. A lot of times, most people, including myself, started off in the constraints of working in a private practice. And although a lot of people tend to take the keep your head down, let's make partner method, I encourage people to not do that, especially in this day and age where even group contracts that are long lasting are, are they may be, a losing game at some point. And to really keep asking the big questions, keep showing initiative, and keep working your way up to the C-suite. Go.
Did you have yeah? Did you have any role models or people that sort of held this option out to you? Because I know for a lot of residents and early career attendings who kind of come up through the anesthesia training track of med school residency and then getting that first job, doing what you describe is pretty uncommon. So it's interesting to me that you kind of became aware of these options and these important questions so early in your career.
Yeah, no, absolutely. Role models all along the way. I started off with academic role models when I was in residency and training, but when I came out to California, I took the goals that I'm going to go into private practice and learn for myself. When I first came to California, the first group that I interviewed with was a community group. It was actually the same group for which I obtained the contract for the hospital several years later. And although I didn't sign with this group the first time, I kept my connections with them. And after a year or two, after I left my first job, I actually joined this group and I started working with these individuals. Now, a lot of these individuals themselves had inherited this group and were, again, a young collegial group of people trying to make it work in the community. So it was really working under their helm for a good year and a half, where I really learned about what it's like to be running a group, the ends of the compensation reimbursement that's received by the group and paid out to each individual anesthesiologist or anesthetist working in the practice, the problems associated with patient care, people trying to jump, or cut corners rather, and provide care for patients who need further workup and all the things that you typically see. And so I learned that just working under their helm. And then actually in July last year, just shortly after we talked last, my colleagues had actually stepped away from the hospital. And having worked with administration, I actually created a proposal. And using my previous colleagues, they were my role models. They actually mentored me with creating my first proposal, which I then sent to the hospital. Although it was initially rejected, they did come back to us and we did go forward with that proposal.
Yeah. Do you have any experiences kind of from early on where you began to realize the whole different categories that you had to start thinking in as a business owning physician rather than just a clinician only?
So again, a lot of that came from the independence that was really thrust upon us during the first year. I think a lot of it really comes down to the different pay structure and being comfortable with it. In any groups that I've worked with or run, the biggest question always comes up is how is the group being compensated? And then how am I being compensated as a person working for this group? And then a very relevant question is how long lasting is this? How strong is your contract? So that was really, those three questions were my three really only questions. How do I get set up to be someone who works in a private practice compared to your traditional W-2 employee or a non-S corp 1099 working for a private practice? After that, once I did start my practice last July, a lot of the questions, came up as to, first of all, how do I manage my group's daily operations? Every profession is different, right? Whether you're in financial planning, whether you're in engineering or software industry, you've got something, whether it's a huge time-consuming or money-consuming factor that really it really is the essence of your job. And I hate to sort of say it, but when it comes to contracted anesthesia groups, Justin, we are technically glorified anesthesia staffing services. We staff the hospitals with high quality providers that can provide means to make an ends meet. In other words, provide care so that surgeons can be happy and surgeries can be done in a safe manner, in a time sensitive manner, in a way that keeps the hospital profitable, keeps the patients safe, and keeps the surgeons happy. So when I eventually realized, after many painstaking experiences, that that's really the main tenets, really, of what hospital sees us as a role, then I really started transitioning myself into being like, okay, well, now we really have to deal with the intricacies of staffing. And that's where, I started learning about the real business, and things that affect any profession. Whether it be, someone who's staffing a fast food chain or staffing a hospital, really the issues are the same. And I've actually talked with colleagues in different industries. So really I can touch on some of those things, but really when it comes down to staffing, we're talking about call schedules. We're talking about people who don't want to work with the type of surgeon or type of surgery. We've got people who need to go home early to take care of their parakeet, and you're having to go and find someone to take care of them. I kid you not. And I think I told you last year when I was trying to get married, having to come and take over for someone who didn't want to take call. I was like, oh, I'm too tired. I want to go home. And I have to be understanding of that, right? You don't want a colleague who's too tired taking call. And you have to really learn that you are taking care of a glorified staffing service, which is fine. You're experts, you're full of experts, specialized trade. But you still, like any other profession, any other day, you're still 24/7 there, having to make ends meet when other people cannot. And that's what I learned about the business.
So, with the different places where you were, running essentially an anesthesia staffing company, as you described it, talk about sort of how you went from a private practitioner in the sort of the profile of that role to now I'm running a company. I have maybe a couple docs, maybe a couple CRNAs, and I'm trying to contract with hospitals, surgery centers, other sites of service to be able to, that feels like a big chasm there. Can you talk about that
There is.
transition?
Exactly. So let's talk about the chasm. The chasm typically comes in the form of a request for proposal, or RFP. Essentially, this is in a term for when a hospital is inviting another group to come in and provide services on their behalf to help with their own operations. This is in contrast to what we've been traditionally thinking of, where someone is employed directly with the hospital and there is no glorified anesthesia service or any group in terms of the contracted anesthesia services group. So that was really the gap in terms of coming down and creating a proposal, and especially creating a proposal for a medically underserved area. I want to go over the major tenets of this because this is where you really have to make the gap. So what a hospital is asking for in a proposal is really, at the end of the day, they're asking for a number. What this number is how much money that the hospital needs to pay your group a day, with some caveats, whether it be calls or other things that you want to add in order to make your group run. Now, the business side here is that you have to know, first of all, what the group is bringing in. You have to know the payer mix of the hospital. That's information that can be garnered from a mentor or from a billing company. In my case, I was lucky to have both a mentor that was able to talk to me about what this hospital was like, as well as the billing company. It was a really well used billing company in Southern California that was already doing the billing for this hospital and was able to provide me with the payer level data for this hospital. So once I know what it's like to run this hospital, run this anesthesia services in terms of number of operating rooms, number of calls, types of services, I then combine that with the information I get in terms of how much money we're getting from our insurers, our payers, from the cases that we actually do. And realistically, that's actually the hardest part. I'm going to touch on that in a second. And then combine that with the number that we think we need from the hospital in order to make our group run, and run in a sense that it makes sense to me to take the time and energy to do so. That's the number they're looking for. And that number is usually per daily rate, or it can be done per month. So that's one of the biggest things. That's really the most important thing that they're looking for. And so obviously you don't want to just slap a number down on a piece of paper. You want to show how you come to that. So the next part, Justin, is coming up with, all right, so I know what money is coming in. And in order to justify what I need from the hospital, I've got X plus Y equals Z. In order to justify the Y component, I need to justify my staffing services. In other words, I need to justify my team, how many people I'm going to have there per day, who's going to be on call. But more importantly, and this is the thing that people continue to struggle with hospitals, is determining fair market value salaries, proposing them and deriving your numbers from that. This is very important because not a lot of groups do this. I'm fighting the competition of groups, for example, that want to come in and just underbid or have no bid at all. They request zero money from the hospital, and they cover the money. They cover the hospitals, the staffing with money from other hospitals, or they take a loss, which is what a lot of private equity firms do, for a hope that they'll have a bigger gain several years down the road. So that is, one of the things that we have to deal with, but we have to justify that, and strongly so, as to why we are having fair market value salaries and not the lower salaries that previous groups have been bidding and what the hospitals have been previously used to. Lastly, actually, those are really the biggest thing. I'll summarize them for you here: is determining fair market value, determining the number of staffing solutions, and that's both anesthesiologists and nurse anesthetists, determining their payer mix and how much money technically is coming in per month, taking into account, for example, the coronavirus epidemic definitely impacted us. And obviously from a business sense, then taking into account, billing expenses, first year, second year fees, cash flow, and then obviously last but definitely not least, your own salary, your own directorship stipend. So those are all the elements that come into the proposal, and those are all the things that are needed in terms of being comfortable to make the jump from being an independent anesthesiologist working anywhere to going and even thinking about having your own group. You have to have a sense of all those things before you go and you try to obtain a contract.
Got it. And there's a lot there, obviously. I want to unpack a couple of those items specifically. So we talked about payer mix, and this is a topic that's come up a lot in the show. Maybe for our listeners who have heard, good payer mix, bad payer mix, this is a phrase that we hear and we understand, like, there's a government payer, there's a commercial payer, there's a difference between those. Talk a little bit about how that applies for you in anesthesia contracting and the types of situations you're looking at, and maybe give a couple specific examples.
Absolutely. And I want to preface what I say here, and I want to make a strong point of it, that what we talk about here is not covered in most residency training programs. A lot of people, including the program that I work with right now, have come up to me, and I've actually created the same curriculum for them. It's well vetted with the department. So when we talk about payer mix, first of all, payer means insured. The patient's insured. Well, payer mix basically means that in a practice, you've got patients coming in that are representing multiple insurances. They can be regular straight up insurances such as Medi-Cal, Medicaid. They can be private insurers such as your EPOs, PPOs, your Blue Cross, Cignas. And then you can have a little bit of a cross. You've got managed cares and IPAs, basically small local groups that create sort of contracts in terms of insurance companies to provide subsidized services. That's also a level of competition for us. And so you've got a whole range. You've got county health plans. And then on one end, you've got people who come in are self-pay, people who come in and pay cash for their services. All of these things make up the payer mix. And when you average it out, these are the numbers that you need to know in the number of patients, the proportion of patients that are represented in each payer in order to get to your Z, the amount of money that you're getting in from collections. So let's talk about that. Our group so far has been focused on medically underserved areas, which really focus on low cost payer mix. We're talking about Medi-Cal, Medicaid, a lot of the managed care services. So I'm going to give you some specific numbers and examples. And again, this is really high yield stuff, so please pay attention. When it comes to, especially, and one more thing, actually, a lot of these numbers are also based not just on, contracts between billing companies and hospitals and insurers, but also significant geographical variation. So the numbers I'm going to give you are based on California, specifically Southern California. So when we talk about Medi-Cal, Medicaid, which seems to be the name of the game. More patients representing these every single day and are urged to provide care for these patients. We're talking about the lower cost in terms of the collections that come in. In anesthesia, we look at units, or unit value, or overall a relative value, RVU, relative unit value, a relative value of a unit. So that usually is made up of three things: a base unit, a time unit, and a risk unit. The base unit depends on the type of case that you're doing, with more complex cases like spine cases, neurosurgery, transplant cases having higher base units. You have a time unit, which is done slightly different, but mostly 1 unit for every 15 minutes of anesthesia time. And then you have risk units or modifiers based on, is this, for example, a complex patient, ASA 3 plus? Are we turning the table, doing field avoidance, doing special lines, different kinds of monitorings? These are things that you have to know we bill for, but not necessarily collect for. And I'll touch on that a little bit later. So this base plus time plus risk creates the number of units that you get for a case. Okay, so that's what we know. And so that's one piece of data that we have to get from a number of cases that we are doing in the hospital. So going back, when you're grading a proposal, in addition to your payer mix, you also want to know what type of cases and how many cases you're doing. Now it comes to the insurance value. So there's a dollar value. It's very different for each insurance. For example, when it comes to Medi-Cal, Medicaid, we could be looking at $11 to $14 a unit. Okay. To put that in perspective, when we look at some of our higher paying insurers, and you have to understand that there's groups and there's hospitals that really already, they're the cream of the crop. They have the better payers, if you may. We're talking about as high as $40 to $50 a unit. More realistically, $30 to $40 a unit here in Southern California. So think about the two numbers that I just told you. I just told you $11 to $14 a unit on one end, and I told you $30 to $40 a unit on the other end. Justin, that's a magnitude of 3 difference. So if you can imagine, if you had all commercial payers, you might not need any stipend from the hospital. The number that you request, the daily rate that I was telling you about, you might not need anything. As a matter of fact, if you go to surgery centers that just have commercial insurers, oftentimes the groups are paying the surgery centers to work there. People will be sending fruit baskets and flowers and candies, and just to keep up the good rapport. Or some places actually pay. Which is actually technically illegal. It's a kickback, but think about it. It's very different from the community setting, where I'm focused, where we have much more of the lower cost units. And so, we might be dealing with an average of $17 a unit, all things considered, considering a lot of these hospitals are almost half or more, 60% Medi-Cal or managed care, which are, again, local groups or local insurers that then take care, or extensions of the Medi-Cal Medicare plans. There is some variation when it comes to, and this is another topic I definitely want to touch to, in terms of the type of what we call provider, and I hate that term. It's an anesthesiologist versus nurse anesthetist. It's very daunting to hear this, but you must know that the vast majority of insurers do not differentiate between anesthesiologists and nurse anesthetists. So they don't know if it's a CRNA or an anesthesiologist doing the case. Medi-Cal, Medicaid might be one of the few that do, and they pay $2 a unit less. So $9 a unit instead of $11 a unit. So I gave you a little bit of information there, which can kind of give you a little bit of the frustration that groups must feel when they're catering towards the lower numbers.
Yeah, before we do that, let me just briefly kind of rehash to make sure that I and our listeners all understand this. So, especially in the RFP process, part of what's going through your mind is how much revenue, how much money can my company make from a hospital engagement based on the payer mix, based on the volume, and based on the complexity of the procedures. So there, to use simple round numbers, there's 100 patients a day, and the average I guess like number of units, which is a function of the complexity, is going to be, I don't know, 5 units per patient. So there's 500 units, and that yields, as a function of the payer mix, 5 units per patient, 500 total units, and maybe $17 per unit that's the revenue number. So what you're doing then is you're trying to understand how much is in play in terms of total revenue, and then how can I competitively, make a bid for that business in a way where I can get enough money to pay my people and keep the lights on. Is
So let
that
me give you an example, actually, based on what you just said, and I'll boil it down to that of a day. So let's take your example. Let's say we have 100 patients, and let's say that we expect to bill between all the cases, let's say about 15 units per patient in a day. So that comes out to about 1,500 units a day. Okay. So I know that of those units that I'm getting from insurers, the $17 a unit. So that's my X right there, right? So X plus Y equals Z. The X is my 17. I know my Z. I know that in order to make my group run, in order to pay the guaranteed salaries and stipends that I've created in my group model, I need to be making about $32 a unit, a net. Okay. So I know that I'm getting $17 a unit. So Z minus X equals Y, 32 minus 17 equals 15. So I need to be making, or I need to be receiving, or rather, the proper word, I need to be subsidized about $15 per unit. Now, there's different ways you can go about this in your proposal. If you have, this is where the business acumen comes into play. You have to be willing to take a risk. Be like, oh, I'm making X number of units. And I had to take, let's say it's a rainy day and I'm not making as many units, and I have the same number of people there. I know I'm taking a little bit of a loss, so I might need a little bit more than $15 a unit. So you start adjusting the numbers based on the variations, seasonal variations, other services offered. Things can be great. Oh, we've got some anesthesiologists looking at nerve blocks. We're going to be building more units. This is great news for us. So all these things you have to take into account, because you need to hit that 32 or maybe 33 if you want to make any kind of profit, or reasonable profit for your group. And so you have to be able to get that number, and you use all these things that you play. Your insurers, the number of cases, who can do additional services, value-added services like nerve blocks, post-op checks, pain services, and all that. Yeah.
And it's important to point out that this XYZ, I really love this basic algebra. It's taking me back to like my 7th grade math class. For that Y variable, what you described as the subsidy, this is mathematically describing how sort of out of whack this is. That the cost of providing anesthesia services is what you can earn doing it, plus a bunch of money that the hospital has to throw on top in order to pay the people to do it. And I think one of the things we've talked about in the past is CMS setting reimbursement rates for all the different specialties. Anesthesia is one of them. And actually this year it's getting cut 10% again year over year, which is absolutely nuts. So if in a perfect world, there would be no subsidy, because the anesthesia services themselves would reimburse enough to be able to cover the costs of the people doing the work, right? But because of it gets political and weird, and this is certainly beyond my core area of expertise, but what we see is that because CMS continues to cut reimbursement, that subsidy required from the hospitals is bigger and bigger and bigger, meaning the hospital gets paid on all their anesthesia services, and some of that goes to the anesthesia group, and then the hospital throws another 500 or 750 or $1 million on top just to be able to make things work. And so that variable Y, that subsidy, is actually the token. It's the number that an RFP is kind of being negotiated around. It's like, well, Dr. Shah's group needs a $500,000 subsidy. Maybe this other group, they'll claim that they only need a $200,000 subsidy. So that's where the difference in the proposals is often manifest.
Absolutely. And a lot of it's not just once you have the proposal, and even if you have the contract, it's about maintaining it and increasing the understanding about that. Why? You brought up a great point. For example, for everyone to know, Medicare reimbursement is decreasing yet again. What that means is practices like mine that receive quite a bit of collections, take care of a lot of patients who are represented by these insurers, we're going to be receiving a little bit less collections. So you would expect that, hey, if you're receiving, 10% less for, let's say 50% of our patients are Medi-Cal, that we would need about a 5% increase in what the hospital gives us for that Y the following year. No. That's likely does not happen. Most groups or most hospitals will really look to have groups to try to decrease their subsidies over time. And from a business point, that absolutely makes sense, right? You want to be more productive as a group. You want to bring in more surgeons and more patients, through long-lasting relationships. You want to bring in more value-added services to yourself so you can decrease what you ask for the hospital. But to a certain point, you can only get to a certain point where you increase your productivity, as everyone very well knows, you can sacrifice the quality of patient care. So there is a limit. And so we have to help hospitals understand that, hey, they're going to continue to get great direct subsidies from the government, but they don't understand that we're going to be getting less from the insurers that are sponsored by the government, and that there is a need to pay more, and they have to understand that if they want the same level of quality of care. Unfortunately, it's a losing battle in most cases. We do have a lot of groups that come in and try to do the opposite. Instead of increasing the hospital's understanding of why that Y has to go up, they're like, oh, let's go down on it. If you give us more hospitals, we give us this contract, we can come down. And think about it, if you have a big practice, which I do not, which has multiple hospitals and surgery centers, you can make that work. You can go and propose a lower rate. Now, I did know that when I proposed to the first hospital last year. I knew that I was also one of the cheaper. I was probably the cheapest bidder, and I knew that I would be so because, on one side we're dealing with people who want to underbid groups, but then you're also dealing with the bigger companies that have higher operating expenses, that actually do care about, paying fair market value salaries there, and then, doing whatever it takes to make their profit off of that. That's a whole other topic. And they were much higher in terms of their daily bids, almost orders of magnitude higher. So I knew that I was trying to go for a sweet spot where it was something realistic. It was something that would keep me competitive against bigger companies. I have a smaller company, I can deal with a lot more myself than like a 200 people company where 150 of them are all administrative. Again, administrative costs tend to be the biggest. And so I kind of knew these things just in going into it. Unfortunately, it is every year they still want to keep or decrease that number for the group. Or conversely, find ways to increase their own OR volume. But again, that might increase some of our patients, which are paying less than our needed value, and we still need subsidies for those patients. And so a lot of these groups find that, hey, they're increasing our volume, we're getting more patients, but we're not getting the incremental increase in the subsidy needed for that. And they start taking a loss over time. Instead of being able to grow with the hospital and grow with the increasing surgical volume, they tend to get left behind.
Yeah. So you mentioned that this model presents some challenges or frustrations for a group in your position. Talk a little bit about how that has played out, how it played out in this situation.
Yes. I'll talk about a couple of things, and I'll mention the coronavirus. I mean, we cannot go without talking about that. So, the number one frustration was day one. The first frustration was not so much from administration, but was from, again, we're a staffing group, we have to deal with issues. So actually, I'll be honest with you, I had a nurse anesthetist that was hired to work with me that decided not to work with me 2 days before. And so I remember working 24/7 for 11 days in this hospital while I was trying to rehire and hire other people. So the frustrations of people who don't want to show up, or just, typical things, people who've got professionalism issues. Then you've got the issue of clinical competency. And this is really the second thing. I know I talked about the staffing solutions, but clinical competency was another thing. And this is sad because, I'd be working with anesthesiologists. Again, we're trying to protect our trade as anesthesiologists, but I see a lot of them not being able to do simple procedures, important procedures like epidurals and spinals for laboring pregnant patients in the community. And this is a very big problem because not only is obstetrics and labor and delivery a big portion of every community hospital, it's a cornerstone. There's also a significant amount of risk associated with these procedures. So there have been a number of times where I have to come and rescue or either take over a case and have to do something after there was significant concern that my colleague was failing with the procedure, or they simply were just doing it improperly or very unsafe. So dealing from my own group with professionalism, staffing, and clinical competency issues. Then from an administrative portion, the frustration issues are dealing, and what I'm still dealing with is being able to deal with difficult personalities and the patient safety issues. Again, we have to be able to deal with, people that are sad, angry, frustrated. That's the name of the game. That happens everywhere. I have no problems with that. What I do have problems with is when it comes to patient safety issues. When you've got what I call the breadwinner surgeon in a small community hospital that brings in about 40% of the volume, but is causing all of the safety issues. We're literally like cringing right now thinking about the experiences we had to go through. But it was frustrating enough that we actually did not renew the contract with this specific hospital in June. And there were significant issues that happened thereafter. And it was one of the things where, we continuously had to, I had to continue to stand up for my group, but then had to deal with the, administration being like, okay, well, your provider doesn't want to take care of the patient. Who's going to take care of the patient? Or this patient's been here. We need to do this. A case on a Saturday when we're not supposed to. And we were asked to continuously, bend backwards or break medical staff bylaws and do things to cater to surgeons. So this is really the biggest thing, is that we're a catering service to administration and surgeons, over and top of the professionalism and clinical competency issues that we have to deal with in the community.
Talk a little bit about, as much as you're able to, kind of the operating room dynamics, and the sense of responsibility that you have for patient safety, and the complexity of dealing with that responsibility when you're in an OR with a surgeon who's the big breadwinner who basically gets potentially like whatever the administration wants to keep them happy as somebody who's driving a lot of volume. How do you navigate that as a business owner, as a physician? That sounds very complex.
That is, and that's in full transparency. That's usually, sort of the role of most anesthesia group leaders. You're always going to have a difficult personality. It just is, and you have to be able to deal with that. But you have to be able to draw the line. Now, when I lived this entire last year. My colleague and I, who are both in the OR with a specific surgeon, and having to deal with these issues. Have a list of 87 complaints, things sent to, medical boards and stuff, and, peer review committees. And it's very frustrating, when you're dealing with it and you don't feel like your voice is heard, even by your own other physicians that are, on the medical staff with you. It's extremely frustrating and scary when, even your colleagues are in the room dealing with a specific surgeon. And your decisions they can be some of them can have harsh personalities, which is fine. But and this is very important for you to note, Justin, the most difficult thing to deal with are surgeons that take away your ability to self-govern as a group. What do I mean by that? In the OR, we have to be at the helm of the ship. If there is a patient safety issue, we have to note it first, because I can guarantee you in these community hospitals, nobody else will. And we have to speak up. And we have to say that, hey, this is not safe. We need to do A, B, and C before we bring patient into the room. However, if we're doing that, especially if you're doing that with other nurse anesthetists and everything, a lot of the surgeons will not like that. A lot of surgeons are used to people just keeping their heads down and just crossing their fingers and nothing bad happens under anesthesia. So then when I bring in a group of strong voiced individuals that actually want to say something, we run into a lot of problems. And it came to the point where, the surgeons or this specific surgeon, who really only one, was basically ignoring us, telling everyone in the OR to ignore us while we were in the room with the patient. doing things like wheeling the patients in, trying to take over our care, overstepping boundaries, and taking away our ability to self-govern. The most important thing.
Did that surprise you when you experienced that and it persisted?
So I knew some was coming into it, but with this specific surgeon, this is way, way above. I don't think I've ever dealt with anything like this. But I have dealt with other difficult surgeons, and I mean, it's a walk in the park compared to my experience last year. But regardless, I also have to think about what my colleagues are going through when they are taken care of, and it is daunting because when someone's mad, when someone's angry, um, it makes you do the opposite of your job. Our job is supposed to be vigilant and have a strong voice. If we're scared, I remember my first years of training, coming out of training, I might be intimidated. I might not want to say something, or I might tell somebody else, and chain of communication gets dropped somewhere. So it does become very, very scary in a situation where lots of things are changing. The surgeons are not willing to communicate effectively with you, and then you're wondering, how far can you stretch your own boundaries of safety, before you say something that could irritate somebody. You shouldn't have to do that. You shouldn't have to be worried about irritating the surgeon. You should be worried about the patient and the patient only. Unfortunately, I can tell you most of our job, like I said, we're a glorified staffing solution that really need to make sure the surgeons are happy. We have to make sure the administration is happy. And the patients should be happy. And obviously, that's the most important thing. And hospitals will tell you that. I can tell you last year, I pride myself on this. Our only complication was having 4 patients with postoperative nausea, no other complications. I can tell you the hospital didn't care about that at all. And they were focused on the number of phone calls they were getting from the surgeon on the weekend about, why we were intervening in her care. Yeah.
And this was a big enough problem for you that you basically said, this isn't worth it to allow these patient safety issues to persist under our watch. So we're going to.
I mean, I spent thousands of hours. I spent thousands of hours doing what I call value-added services. I took over the supply chain management. My colleague and I actually helped them hire their OR director. A lot of these community hospitals, can't even, have issues with their own nursing staff. They didn't have a single full-time nurse in their operating room. You can imagine how difficult that is. And then having to integrate your group, trying to propose changes that are long lasting. None of it's going to be long lasting if you don't have a good perioperative team. And I guess that's another frustration that I forgot to mention, was not having a good perioperative nursing staff in one of these hospitals, at least, where we could have long, things that actually stick.
So there's obviously a lot to learn here, and a lot that I'm sure if you're doing RFPs in the future, you're going to know a lot more questions to ask. How do you envision this evolving? I think, and we've got an episode coming up about this shortly, but with the way coronavirus, and I don't think we're even going to have time too much in this episode to talk about coronavirus impact, but it has dislocated some of I'll say the establishment of the anesthesia companies that employ a lot of anesthesiologists, and the way that the ownership of those companies are structured. And there's flux right now between like big private practices, physician-owned groups, and even academics, and this whole like ecosystem is getting shaken up. So I think there may be an opportunity for perhaps like a renaissance of physician ownership. I'm hopeful, a renaissance of physician ownership in this space. How do you see that potentially unfolding, and how are you thinking about, for your career, for your companies and businesses, and future RFPs, future hiring, staffing, the future of your specialty? How do you see that evolving?
So, the honest answer is I don't really have a strong, good answer, at this point. It's very difficult, with the frustrations that I told you, what we're trying to get to ideally is having, again, the physician autonomy, which I just told you, the ability to self-govern is compromised. You need to have, an understanding of, what it's like to have an individual physician or group of physicians running a group, because, unlike big companies, when you've got a small group of people, you got to take their personal lives My wife's pregnant. I can't keep running a group. That's why I wasn't going to run this group in this hospital if I'm going to keep dealing with issues and phone calls from angry CEOs in the middle of the night. And so, we have to be able to find ways where we have autonomy and we can actually retain our independence and value rather than, oh, you're our middleman and you follow our commands, because that's what most of them are. And so how do we navigate away from that? A lot of it is I've always prided myself in value-added services. I briefly just mentioned that a few minutes ago. But like I said, we can come in and be viewed as a glorified staffing solution, or we can actually do other things. So in all my proposals, we talk about supply chain management, which it's a broad term. You may have heard about it in the whole coronavirus outbreak. It's basically the flow of supplies from vendors, the contracted vendors, into your central supply, and then from your central supply into your anesthesia or OR workstations. Then we talk about, we call root cause analysis or continued quality improvement, which is usually done by the hospital anyways, but where you review your own cases and you review them with your colleagues and you're like, hey, your good documentation practice could be improved here. Or, hey, we could talk about your anesthetic over here. Or why did you label this patient ASA 3? Or knock on wood, if there was an issue with the patient, you would be there doing a root cause analysis, looking at why this error happened. And so a lot of these things are usually taken for granted. Again, these underbidding hospital anesthesia groups are not going to have an incentive to do these other things rather than just staff the ORs. And so by doing more of these things, people realize that, hey, well, they see more of your face. You can't just simply be, someone staffing the OR front desk and a couple of people keeping their head down in the OR. If you want to save yourself in the hospital, you have to be walking around the entire thing. You have to be networking, introducing yourself, going to medical records and making sure none of your records are delinquent. Doing those things I talked to you about, talking with engineering about issues in the OR, is making yourself seen and known. And that can be very hard because as a group leader, then you not only have to propose a salary for your group, for your basic directorship stipend, and then for your clinical involvement if you work in there, but then you have to be able to bite the bullet and be able to do these things without asking for more money for these value-added services. Remember, the hospital sees your group as there to provide, to staff the ORs. They know you have to do these other things, but they don't expect it really because no one else has really done that. But these value-added services can really help with longevity. But really, the other things, and unfortunately, I hate to say it, is the people who tend to keep their head down and not complain about a surgeon or a issue in the OR, they tend to get away with things. And I've seen that the people who are very quiet tend to do very well in private practice models, or even running groups. And it's something where I've butted heads, and I am butting heads as we speak with people. But I pride myself on that. I was like, I'm going to run a group and I'm going to do this. I'm going to hold myself to fair market value salaries and, good treatment of my staff above anything else.
Yeah. Well, it's been really invaluable hearing your story, your experience. I want to have you back, Dr. Shah, to just continue this conversation because I think there's a lot of really valuable things in here that it's information that's very difficult to access. It's so practical and actionable. And these are concepts and ideas that impact every physician working in America, understanding how your group contracts with other groups. And the implications are real, actual, and experienced every day. So I really appreciate your time today. Thanks for joining us here on APM Success.
Thank you very much, Justin. Thank you for your time.
If you liked what you heard this week, head on over to apmsuccess.com, where you can find more content and free resources to help you build a successful career in anesthesia and pain management. If you wanted to leave a review in iTunes, I'd also really appreciate it. Thanks for using some of your valuable time to join me today on APM Success.